Everybody knows me as a spine surgeon, but I'm a neurosurgeon. I did lots of brain tumors, and I did what would be considered crazy stuff.
What? You did crazy stuff?
I know, it's unbelievable, huh?
That's out of character.
Yeah,
Wow.
I know. So let's see here. I have Dr. Coach already. The email with the link is sent. As soon as I know you have plans, it's Friday, and you should not live like a doctor. So as soon as Dr. Coach chime in, we
Yeah,
let
those
you
are
go and start your weekend. And the idea is about talking about this special thing that you have to pay attention. If somebody has a brain tumor, well, how does it present? And we are going to choose a brain tumor that is the most, probably one of the most common brain tumors. And the good news is this is not a cancer. This is a brain tumor that we can treat very effectively. And I would love to drill you a little about the what brain tumors are out there and what is kind of thing and so on. But when you hear the name brain tumor, what do you think, Amanda?
Well, actually, one of my best friends, so it's different for me. One of my best friends had a brain tumor when she was like 3, and she got it removed and she's feeling safe and healthy. But when I think of a brain tumor, I think of a tumor
Not
on the
good,
brain.
huh? Not good.
Yeah, really bad.
Yeah,
I
you
think
always think
they,
about bad. There is a reason for that because a lots of brain tumors are something we call glioblastoma or glioblastoma, and we have even a longer name for that. We call it glioblastoma multiforme or GBM. These are mostly deadly tumors. They're tumors that once you have it, we can extend your life, but we cannot really get rid of the tumor. But that is just probably just half of this story because the other half are lots of tumors that we can treat in neurosurgery and successfully get rid of the tumor for you. And your friend is a example of that. Based on the age that you said she was 3, most likely she had a or he had a what we call medulloblastoma. Medulloblastoma is a tumor that grows in the back of the brain. We call that cerebellum, and that tumor, depending on the graduation, we grade it from 1 to 4. If it's grade 1 and 2, it can be successfully treated with surgery and other treatment. Now, how is your friend doing now?
fine.
No problem, huh? So
Problems, I mean, not related to that. So,
yeah, I don't want to go to details of that. So here comes Dr. Coach.
okay, bye guys.
Bye. Let's okay. Thank you, Amanda.
Thanks.
So, Dr. Coach,
Yes, here I am.
welcome.
Thank
And we are
you.
going today to talk about brain tumors, and I'm going to present a brain tumor case. Um, Amanda and I, we talked a little about the benign versus malignant brain tumors,
Hmm.
and these are the two main categories, right?
Yeah.
In the malignant category, what comes to your mind?
GBM.
GBM, glioblastoma multiforme.
Hmm.
Or there are some other malignant brain tumor, gliomas that grade 4 gliomas, or medulloblastomas that are grade 3 and 4, or anaplastic astrocytoma.
Yeah.
But there is a,
Hmm.
let's talk about that in a different time. Let's today talk about the most
Nine.
prevalent and benign brain tumor.
Okay.
What comes to your mind if you hear uh, benign brain tumor?
Meningioma is the first thing that comes to my
Meningioma it
mind.
is. That is what we are going to talk about. And
Okay.
now I'm going to actually share my screen here with you. Are you able to see my screen?
Yes,
Let me
I can see
actually
it.
do it a little differently. And I'm going to share my screen with you now.
Mhm.
And here it is. This is a 55-year-old patient comes to the ER patient is just confused.
Yeah.
Comes to the ER and it just have not a really bad headache, but chronic headache. Patient is confused, and that is the main reason, very unspecific, to come to the ER. Now, coach, you are in the ER. You are the doctor in the charge of ER. What are the things you are going to check on the patient that comes? You don't see this picture yet. All you
Okay.
know, this is a patient come to the ER, is confused, has some headache. What are your differential diagnosis, and how would you investigate this patient?
The first thing I would probably do is get a CT head, just to check for a stroke, to rule out some kind of major stroke, bleed, or something like that. So that'd be my first step for sure.
Well, obviously, even before that, you get the vitals, you check for
Of
some
course,
labs
yes.
and so on, but examine the patient. But the first diagnostic thing after that, you have done the labs, and you check, make sure that the patient is not intoxicated, is not nothing poisonous. But yes, head CT is a major part of headache, confusion, and you're mostly looking for stroke. But this is the CT of the head. What do you see?
Nothing really. Well, let's see. That is not. I don't see anything bad about that. I don't
No,
see
well,
any kind
here
of.
it is. Let me show you. This is a axial CT of the
Yeah.
head in the tissue window, not the bone window.
Mhm.
First of all, you see that just here, even on the left side, you see there is a midline shift.
True. Yeah.
You
I
see
can see
that what we call the falx, or the membrane that separates the two sides of the brain, is pushing from the left side to the right side.
The
As
right
we
side.
know, the sides are flipped. More than that, you see some calcification and something right here on the left, what we call parietal area of the brain. And once you see this here,
And we see that. Yeah.
this is the non-contrasted. But even in the non-contrasted, you see something there. You don't see the sulci and gyri of the brain. Based
Right.
on this, you are going to order a contrasted CT. And here you are on the right side, you see the contrasted CT of the brain, where you see a huge mass
Yeah.
that rising from falx, and it's almost size of a bigger than a baseball. And here, then, based on that, you are going to order now an MRI.
Yep.
And this is the MRI. You see in the coronal view a huge left-sided mass. And now all of a sudden it makes a little sense that the patient is partially confused, because the language is as well is involved in this. And you see that this mass grows along what we call the dura on both sides, and it multilobulated and very solidly enhanced. When I see something like that, my first differential diagnosis is meningioma. Obviously, at this point, you consult neurosurgeon. When I come and see this picture, my first differential diagnosis is meningioma, second is meningioma, third is meningioma. Mostly because if you look carefully here, you see those dural, what we call adhesion of the tumor to the dura. And look at that, the tumor grows through the skull, goes actually extracranially. Very few things can do that. Like sarcoma can do that, but sarcoma, the borders are not that clear. So osteoid osteoma can do that. So osteoid osteoma, meningioma, osteosarcoma can do that. But by the nature that the surrounding tissue is not showing any edema, because if it's a carcinoma, it's a very malignant thing, it sort of just bothers and irritates the hell out of surrounding tissue, causes lots of edema. The fact that there is not much of edema here indicate that this has been growing very, very slowly and not irritating the surrounding tissue. That more or less limits the diagnosis to meningioma. more or less.
Mm-hmm.
So this is going to be a very quick case for the ER doctor, because at that point you just pass this to neurosurgeon and you're done with it. Because that is highly specialized things that only a neurosurgeon will deal with. But let's dive into that. Dr. Coach, what are the symptoms you would be looking in this patient, and what are the things that could make this an emergency?
Well, as far as symptoms goes, I would say a lot of times they would have a headache, especially when waking up in the morning. They might be nauseous, vomiting,
Yeah,
dizzy, which you said, I think you said he was dizzy actually,
yeah.
and kind of confused. It could, you have a mass effect, I think is the biggest thing to worry about. So worry about the fact that not so much that it's going to grow into sort of ingratiate itself into the brain, but rather push against things as it grows, push against areas of the brain. That could be a problem. So if it was more towards the brain stem, that could be an emergency for sure. It could press on the brain stem, and then you could have respiratory distress.
But even
You can
before the
stop breathing.
brainstem, look at that structure, that dark structure within the brain. What is that
Mhm.
structure?
Is that the corpus callosum?
No, corpus callosum is actually part of our white matter that is above this structure, which is
Oh, okay.
pushed
Oh, this is the
down.
ventricle. The ventricle
That
you're
is the
talking about.
ventricle.
Oh, yeah, yeah, yeah,
Yes,
yeah, yeah,
yes,
yeah,
yes.
yeah, yeah.
This is corpus callosum. This is the
Hmm.
ventricle. And
Yeah.
if it starts, we have obviously four major ventricles in our brain. We call them the lateral ventricles, and then they come together. They become the third ventricle, and they go to the fourth ventricle. Any structure that obstruct the flow of the CSF, which is mostly
Hmm.
produced in the lateral ventricle,
Hmm.
it's going to cause a picture that can become an emergency. Do you know what that picture is called?
Hydrocephalus?
Hydrocephalus, exactly.
Hmm.
Where practically that fluid of the brain doesn't have an outflow and start increasing the intracranial pressure.
Hmm.
What would be the problem if intracranial pressure is increased, Dr. Coach?
The problem is that the skull is rigid. And so if the intracranial pressure is increased, then the brain is pushing up against the skull and it doesn't have any room to move. So it gets squished.
What does
Probably
that
the
mean
best way to put
in
it.
what did that what does that really mean for the brain getting squished? Why would brain care about being squished?
Well, the brain tissue is living matter, and the same way that it doesn't feel good when your finger gets caught in a car door. Well, actually, technically that's not true because your brain is not innervated, so it doesn't
Yeah,
have pain per se, but certainly cells can die
yeah.
uh,
Why?
when
What
they're
would they
starved of
die
oxygen.
of? If there's a pressure increases, what would they the tissue? It's true. What would they die of though?
Ischemia, I would
Ischemia.
guess. Hmm.
Exactly, exactly. That's ischemia it is. Now, the usual pressure inside of our ventricle and so inside of our brain is about somewhere between 12 centimeter of water. Now, our heart is pushing the blood in with our mean pressure, which is around 40 to 60, usually by the time it gets to the brain. When the pressure increases to that level, above 20, especially if it's above 20, and when you get high 20s, 30s, practically the pressure of the blood that try to perfuse your brain is not enough to get blood and oxygen to your brain. So
Right.
practically, your brain asphyxiate, doesn't get enough oxygen, and then it dies. Literally, part of the brain that's what a stroke is. Okay, at the stroke, when a vessel is literally obstructed, the blood so oxygen doesn't get to our brain, that part of the brain that doesn't get oxygen dies. In the here with increased intracranial pressure, actually you get a global asphyxiation of the brain. You have a global the cells globally in the brain die, and it get even worse. Once cells start to die, that adds, when the cells fall apart, they increase the pressure inside of the brain. That become a cascade that at certain point you cannot reverse anymore. So that would be, in this case, there is some pressure, but the ventricles are not. If that start, you will see a lot of big ventricle. That's not the case here. Now, let's go to the next step. Do you know what kind of study this is on the right side?
Yeah, it's let's see, what do we call it? MRA probably?
No, this is very close. This is actually MRA and MRV, venogram. This is
Venogram,
MR
okay.
venogram of the brain. And the reason here you see this is because what you actually don't see. Because if you know, our brain has this major blood flow, we call them sinuses. You do not see the sagittal sinuses because the tumor is obstructing it. In the brain and brain surgery, that's important because if you have some structure that impinges on the sagittal sinus and it goes slowly, eventually it closes the sagittal sinus completely, and that's actually a good thing in this situation because by that time the other flows are open. Brain has time to send the blood through other means. But if you have something that the sagittal sinus, it pushes on it, but it hasn't obstructed, and you go and do surgery, you try to completely obliterate the sagittal sinus, people cannot survive that. In this case, this unlucky man has been lucky enough that the sagittal sinus is completely gone, so you don't see a flow in the middle. That means we can take that tumor completely out and close the sagittal sinus completely. And here you see the irregular arteriogram or cerebral arteriogram, where you see the arteries come in and few moments later you see the venous backflow, but you don't see the massive sagittal sinus that you would expect on the top of the head. Just so you know, these are the orbital area where your eyes are. These are the nose, and this is the calvarium, and you see some venous backflow lateralizing, but you do not see the big sagittal sinus. Now, the next step is, how do we remove that? This is a big surgery. We know that we know that the vascularization of the meningiomas are through the surrounding dura. We have to obliterate that dura before we can safely take that tumor out. So in this case that I did, imagine this is all tumor. The red is the border of the tumor. What I do, we have a machine, we have a drill that goes through the skull and then stop when it's to the soft tissue, the self-stopping drill. I put this blue, you see where I put the drills in the skull. Then all around the skull, calvarium. Then I connect these pieces together and I take a window out. I practically take a ring outside of the tumor out of the skull. And that enables me to cut this area, coagulate the dura here, so cut all the blood supply to the tumor. Because if you try to get to the tumor without doing that, patient going to bleed in front of you. It's going to profusely bleed, and you have no way of stopping that bleeding.
So you can't use a burr hole, you're saying, right?
This is the boreholes. The blue
the borehole.
are
Okay,
the
yeah,
boreholes, but the boreholes are outside of where the tumor is, because if you remember, the tumor is growing through the skull. If you try to put a hole here, then,
I see.
Then you're going to get right into the tumor, and then patient is going to bleed to death.
I see.
So this is what we do. Now, this is how it looked like in reality. This is the tumor. We already cut from one ear to another. Part of the scalp is bent forward. Part of it is backward. And this is all the tumor we separated. We cannot get into that. Now we are going to make a window around the tumor. here, the first borehole, and
Mm-hmm.
then more boreholes. You see those boreholes?
Yep. Mm-hmm.
There are 8 of them. And
Oh,
we
okay.
will run the drill we call the side cutting craniotome that connect these holes together. And once we do that, practically you can remove the calvarium completely. And this is the
Okay.
tumor. This is the
Mm-hmm.
this is actually the brain. The tumor is
Mm-hmm.
already removed. This
Mm-hmm.
is the tumor. As you see, tumor is growing inside
Mm-hmm.
and outside calvarium, and this is the brain. Now, you see very large veins outside because this lucky man, the sagittal sinus is already obliterated, and you see the clamps here on the sagittal sinus, and which are holding it so it doesn't back bleed. If you would do that to a patient that has still flow to the brain, they would die within minutes because the brain cannot backflow the blood. So if it cannot send the blood back, there is no space to get the new blood from the heart. So practically brain asphyxiate and go become ischemic.
Mm-hmm.
Sometimes you can see that brain swells in front of you because blood comes in and cannot flow back. Here, we literally putting a clamp on to see if the brain can tolerate that, and it does. Then we took the rest of the tumor out. And then we have to reconstruct the dura, and this is how you see we reconstruct the dura. Here we use the bovine pericardium, practically the skin around the membrane of the brain that we used to, because we took all the tumor, all the dura on top out,
Mm-hmm.
and then we reconstructed that, and then we put this material, which is a titanium mesh. We shape it in the form of the skull, and then close the skin above it.
Dr.
So
Abbasi, why would you use pericardium and not dura from the bovine? I mean, is pericardium better for?
it's tougher, yeah. And the
Hmm.
bovine dura is harder to get than the pericardium, and as
Mm.
well, it may have some prion and something else. It's easier to
Oh, I
manufacture
see.
and so on, tougher and easier to get. You don't have to.
Mhm.
And another thing that's very important, I know in a human, heart is smaller than the brain. How do you think it's in a cow? Which one is bigger, heart or the brain?
By the way you're asking the question, I'm going to have to say heart.
Yes, yes. It's
Gotcha.
cleaner to get, easier to get,
I see.
because you just
Okay,
open the
interesting.
thing and it's bigger. It's bigger, tougher
It's bigger,
membrane.
yeah.
That's why
Hmm.
we use the bovine pericardium and not bovine dura for this procedure. But good question. So this patient did pretty well, and these are the post-op scans. We see
Mm.
that now all of a sudden you see the white matter, and you
Hmm.
see the actually that the skull replacement titanium mesh. Now, do you know how I shaped that titanium mesh in form of the skull?
I guess you use the flap as a mold.
No, we never use the
No?
flap because flap has tumor. We don't want to touch
Mm.
anything that has can transfer tumor cells. And by the
Okay.
way, that flap is deformed, has tumor in it, is not
Mm.
usable.
That's not usable. Okay.
Yeah.
Then I don't know how you do it.
Well, I use a bowl. They have sterile bowl that they brought to the OR. I
Okay.
used the back of the bowl and put that mesh. I pulled it over and shaped it little by little to the round form. I was
Hmm.
pretty proud of myself when I did
That's
that
interesting.
because the patient did pretty well and the shape of the
Yeah.
brain was quite good after that. I followed up
Yeah.
this patient for a year before I left it UTMB, Galveston, Texas, and
Hmm.
patient did pretty well in that time frame. And um, and that is how we dealt with this tumor. Now, this is a quick case for this Friday. I'm not sure on YouTube. Is anybody asking any question regarding this case?
I was on YouTube before and I got off it to join Zoom. Let me go see. Oh, no, I can't see that. Okay. Here it is. Let's see. People are saying things here. Hey everyone, lateral ventricles, hydrocephalus, herniation of brain contents if there's no room for the brain to expand the skull. Lucas says, good evening. Christina says, no, we've been answering all along.
Okay. Now, Dr.
Okay.
Coach, what would be this? Let's say you're the primary care physician of this patient.
Hmm.
I send the patient back home. You are, you get all my notes and you know what's going on.
Yeah.
What does the aftercare for this patient do you think look like? What, as a primary care physician, how should you be taking care of this patient?
Right. Well, for one thing, the first thing I want to do is I want to do, from time to time, neuro exams. I want to make sure that the patient isn't experiencing any seizure type activity that could imply
Seizure,
some,
extremely
yeah.
important. All
Hmm.
these patients are started on seizure medication,
Yep.
and you are going to now there are many different kind of seizure.
Hmm.
This does not need to be a grand mal. It could
Right.
be like a absent. It
Yep.
could be like non-convulsing seizure.
Hmm.
So, how would you treat your seizure if it was your patient?
If the first thing I would well, after I made sure that the patient isn't in danger of
Hmm.
asphyxiating or anything like that, I would probably take some Ativan and inject some Ativan to
That
maybe
is the
2 milligrams of
acute. That is
Ativan.
the acute treatment
Hmm.
of the seizure. Yes, Ativan
Hmm.
or Valium, something to break
Yeah.
the seizure, and
Right.
supportive measures. Okay.
Hmm.
Now, what about that? I send the patient home with phenytoin. This is what I did for this patient. Meanwhile, we have some better thing and so on. Are you familiar with the phenytoin?
Yeah, somewhat. Hmm.
Okay. Well, it's a medication that has a narrow therapeutic range. You have to measure
Exactly.
the
Hmm.
effective range in the blood and adjust it and
Hmm.
so on. And that is one of the things that you would be doing as a family medicine,
Yep.
a physician, to check the level of the phenytoin. Then
Hmm.
obviously rehab.
Yeah.
You want to send this patient to rehab, ambulation, and
Hmm.
you want to do, as you said, regular neuro exam, maybe every 2 to 3 months. Check on this
Hmm.
patient,
Hmm.
and every 6 month, for at least for initial, get a CT with and without contrast to see make sure the tumor is not back.
Right.
You don't need to read the result, but you have to make sure that the patient sees the neurosurgeon, get the CT, and the levels are controlled, and then uh, practically this patient, at least in the time I followed up with him, had no recurrent of the tumor and did quite well actually. It's amazing
Mm.
what you can do if you know the basic of the treatment.
Yeah.
And even in a tumor that is this humongous, this is this massive,
That was huge. Yeah.
yeah. So, and the question always come back: how did the tumor grow to that size in a patient in the United States?
Well,
That
I
is
think what happens is I think people don't think tumors. People think, oh, I just have headaches. It's no big deal. I'll take some Tylenol or whatever. I don't think people know to look for the signs of, that you might have a tumor. I mean, I've had, uh, when someone comes to me, even a family member, and says, oh, I wake up in the morning with a headache and I'm nauseous, I immediately am worried. That's my first thought. Probably
that's because
nothing.
you're a doctor.
I know. That's true. It's true. It's true. And I automatically want to get a scan. A
Yeah,
CT scan is very easy, very quick, very cheap. That I've scanned people
but
for less.
but there
So
is a pitfall there. You remember the first picture? You said you don't see anything.
yeah,
A CT without contrast, even a very experienced neurosurgeon can miss a tumor in a CT without a contrast, or an
true.
MRI without a contrast. They are not, you always have to, if the, what it made it the decision for me to get a CT with contrast and then MRI was the midline shift.
Yeah, I was gonna say that's
That
yeah.
that
Hmm.
midline shift,
Hmm.
something is not right.
Something
I
is
don't
wrong.
see the
Yeah.
sulci and gyri. Even very
Hmm.
experienced surgeon can miss that. If we
Hmm.
don't have a protocol, we see the patient with a confusion and something just doesn't fit in the CT. And that
Yeah.
something that doesn't fit is that the midline, the folks, is not in the middle.
Not in the middle, yeah.
Mass effect. We call it a mass effect. If you see a mass effect, always go to the next step, get a enhanced CT or MRI. Okay?
Makes
So
sense.
this has been good. Short but good. Any questions from any of the participant or you, Dr. Coach?
I want to know how you deal with the swelling. Do you prescribe steroids, and how long do you want them to stay on the
What?
steroids?
Acute swelling or chronic swelling?
Both.
So acute swelling is dealt with giving, like in the war for this patient, we give mannitol. What does
Okay.
mannitol do?
Right.
It's higher osmolarity. It
Yep.
draws all the fluid from the tissue to the blood. And that is acute treatment. And then obviously sometimes we put a ventricular drain to drain that the CSF to reduce the pressure. Then and some other means. One of the things that sometimes we do, we infuse people with urea. What comes in your urine? Because that as well has high osmolarity and draws the blood fluid from your tissue into your blood. And by the way, your kidney gets rid of it in no time, no problem. So we, excuse my French, we pee in your body, in your veins to reduce your brain
Interesting.
pressure.
Interesting.
Okay?
Okay.
Literally, that's urine. Okay? Obviously, it's not a urine from a person, it's synthetically and so on and so forth.
Yeah.
But
I'm
works
sure.
beautifully.
Interesting.
There are some other ways. Now, in the chronic way, the steroid is a way to reduce that. There are some other things that reduce the, for example, as well, with the osmolar action, to reduce the pressure in the brain. And there is a medication that we don't use, acetolamide,
Zolamide.
acetazolamide. We don't use that anymore because we have better things. But 30, 40 years ago, that was what we would give to reduce the amount of CSF your body produces. But
Yeah.
that we don't do that anymore, or at least is not the first treatment anymore. Hasn't been for a long time.
I had a patient once who had actually had a meningioma resection, was on steroids, and then her behavior took a turn, and my attending thought that it might have been steroid delirium. And so we had to find another option other than steroids. I forget what we ended up using, but we had to take her off the steroids, and she got better when she was off the steroids. But then you worry that the swelling might come back. So it was an interesting case.
Yeah. Now, before we finish that, I want to show you something from a movie called Hannibal. Do you remember this movie?
I saw the Silence of the Lambs. I didn't see Hannibal.
This is the next one where he opened the skull and cut a piece of brain and feed it to the same person.
Oh my God.
We neurosurgeon, we just, what the hell is going on? This patient cannot be awake and not having a sagittal sinus. You don't see any sagittal sinus there in that movie. So we say that's just ridiculous. How can that be? Now, you can cut it with the sagittal sinus, then they bleed and die, or you can clamp the sagittal sinus, then they die of not venous backflow, or
Right.
you can have, actually you can do that. I can cut somebody's skull, expose the whole brain, and actually I can do that. I can cut a piece of frontal brain and cook it and feed them, but I have to keep the sagittal sinus intact. If you want to know how sagittal sinus look like, and I'm going to show it to you, sagittal sinus. And I want to have a realistic picture. So, by the way, this is how sagittal sinus look like in a cadaveric. It's very thick. It's big. It bring a lots of blood back, and this is how the vascularization it look like in the brain. It's the superior sagittal sinus, inferior sagittal sinus. They come together, become the transverse sinus, sigmoid sinus, and then they go to the jugular vein. Okay. Okay. Well, this was a good day. Coach,
Thank
I
you,
hope I
Dr.
didn't
Abbasi. A
gross
lot
you
of fun.
out. I hope I didn't
Oh,
gross you out with the Hannibal picture.
it's very interesting. But it is also
Okay,
interesting that if they did that, the patient wouldn't feel anything because the brain is not innervated.
that's right.
There's
Actually,
no
I did
nerves
a
in the
lots
brain.
of surgeries with patient being awake. If you are
Hmm.
close to certain area, we anesthetize the skin and the skull and then cut the skull out, and then we anesthetize the dura, and then we cut the dura, and then we do the surgery on the brain itself, because brain itself doesn't have any pain receptors. So you
Right.
can actually cut the whole brain tumor out with patient being awake. They
Yeah.
don't feel a thing.
Last question, Dr. Abbasi. When you do a craniectomy, do they still put the flap in the abdomen to marsupialize it, or is that old
That is
school?
a now. Well, let's put it this way. First of all, when do you do craniectomy? When you have a pressure inside of the brain and you want to take the skull out, so skull doesn't limit the volume of the brain, so brain can expand without squeezing itself.
Right.
Now that skull, um, we used to put that under the belly, like open up a flap of the belly, put it there, and so it can survive. In some cases, though, that our belly absorbed that brain. Then when you would
Oh,
come
really?
back, it would just fall apart.
Oh,
So we don't, at
not
least
done anymore.
in my lifetime, we didn't do that anymore. What we
Oh,
do,
okay.
we put it, we double bag it,
Hmm.
we put it in a minus 80 freezer, minus 80 grade centigrade, which is about minus 130 Fahrenheit.
Ooh.
And that can stay there for years, actually,
Hmm.
with the patient's name. When patient's swelling is done, we bring that, we thaw it, open it up, put it back.
Usually it's about 6 weeks or so. How long does it usually take for the brain to calm down?
About 2 months, something like
Two
that.
months.
About
Very
two
good.
2 months or so. Yeah.
Interesting. Okay. Thank you, Dr. Abbasi.
Well, everybody, you guys have a great weekend. I hope you enjoyed this session of a obscure neurological